So my next presentation is a meta-analysis and review of FFR versus IFR in coronary revascularization, and it's a comparative evaluation of outcomes using these different modalities in patients who are undergoing coronary revascularization. So in terms of the background, as we know, FFR is the gold standard for physiological lesion assessment for patients undergoing cardiac catheterization and PCIs or other interventions, but it does require adenosine to induce hyperemia. IFR is an adenosine-free alternative. Since we are not using adenosine, it kind of simplifies the workflow and reduces side effects because some patients may not be able to tolerate adenosine during the procedure. And there have been several RCTs which suggest non-inferiority of using IFR versus FFR, but a long-term safety remains controversial with using IFR. So the aim of the study is to evaluate clinical effectiveness and diagnostic performance of using IFR versus FFR. The objective was to evaluate these outcomes, including major adverse cardiovascular events, all-cause mortality, myocardial infarction, unplanned revascularization, and a diagnostic performance with assessing the overall accuracy, sensitivity, and the specificity. In terms of the literature search, so we again use several databases to find studies using the inclusion criteria of comparative studies on IFR versus FFR in coronary revascularization. Studies which had more than 100 patients reporting clinical endpoints or diagnostic accuracy were included. We did include some RCTs, but as well as observational studies in this analysis. And finally, 5 studies were selected for the analysis. As you can see here, we had prospective studies, observational studies, RCTs, and a multi-center study which were included. All of these studies were assessing FFR and IFR in terms of different outcomes. So in terms of diagnostic accuracy, there was a study which by Meany et al. Which showed that the sensitivity of IFR was 78% and specificity was 83% with overall accuracy of 81%. And there was another study which showed that IFR and FFR both had a comparable accuracy versus using more advanced imaging like SPECT, CFR, and PET. There was a study in 2021 which showed that IFR could be non-inferior to FFR in terms of major adverse cardiovascular events in patients in which IFR is used for assessing a lesion versus FFR. However, there was another study which did show that there could be increased all-cause mortality with patients in patients in which IFR is used as compared to FFR. And some studies do show that it could be non-inferior at a 1 year point, but the study only studied the results till a 1 year duration. So we don't want to know if there could be a difference in terms of long-term outcomes if IFR is used in a patient instead of using FFR. And the secondary outcomes we looked at was myocardial infarction in terms of patients developing MI. In the future, no consistent differences were noted in either group, and unplanned revascularization was slightly higher in the IFR in terms of long-term data. And coming to procedural considerations, IFR does offer an easier workflow because it can be done faster and you don't have to use adenosine to induce hyperemia. FFR, however, has more robust long-term data, so that is kind of the preferred modality right now. In terms of limitations of the study, just because there were different types of studies used, so there was heterogeneity which was interpreted as moderate, and the reasons, like I said, include the different study designs, variability in the follow-up duration, as well as variation in the patient risk profiles and multiple endpoints. Coming to the discussion, IFR does provide a practical and less invasive alternative to FFR, and the short-term outcomes do appear similar. However, long-term data suggests that there could be, especially from this one study, that there could be potential increased rate of major adverse cardiovascular events and mortality with IFR. Therefore, we do recommend that clinical judgment and patient selection on an individualized basis are critical in terms of deciding which modality to use. FFR remains preferred for high-risk patients or high-risk decisions until more data emerges. Finally, coming to the conclusion, IFR is a useful tool, especially for quick decision making in stable patients. But FFR is the preferred modality for long-term prognostication as well as high-risk lesions because we do not have long-term data with using IFR yet. Therefore, further R studies with long-term follow-up are needed and a direct comparison between IFR and FFR for the long-term data. The goal should be to optimize physiology-guided PCI through individualized patient strategies. Thank you again, everyone.